and welcome to the Expert Panel Series brought to you by Brain Matters. I'm your host, neuropsychologist Dr. Alexis Chappell. This series is designed to educate, support, and inspire individuals living with neurologic and psychiatric conditions. Our intent is to bring you the most current scientific information from experts and leaders in the field so that you can continue moving your life in the direction of the things that you value most. Because at Brain Matters, we believe when you know your brain, you change your life. Today, I have the pleasure and privilege of chatting with Dr. Salmaan Khawaja on ways to enhance the practice of neuropsychology for members of the LGBTQ+ community. Dr. Khawaja is a clinical neuropsychologist. He serves as the Director of Neuropsychology and Psychology Services at Bon Secours Mercy Health System. Dr. Khawaja also operates a private clinical practice that provides clinical and forensic neuropsychological consulting. Dr. Khawaja is a colleague of mine, and he is also my friend. Over the years, we have collaborated on a number of cases, and we continue to frequently consult. For those listening, Dr. Khawaja and I are both employed in the neurology division of Bon Secours Mercy Health, but we are not representing that organization in today's discussion. Dr. Khawaja, hello and welcome.
Hi, thanks so much for having me.
Absolutely. I'm delighted that we're able to chat today about the topic of neuropsychology and serving individuals among the LGBTQ+ community. I think as neuropsychologists, we live in this highly standardized world of hypothesis testing and brain functioning, and yet it's so important. If we are to be excellent at what we do, it's so essential that we know our patients and their family dynamics, what they value, and of course, how they see themselves. So I know when we talked about what topic would be ripe for discussion today, you mentioned this very topic. And so I imagine it's been salient for you in the last year. Can you tell me a little bit about how serving this community became a part of your clinical practice?
Sure. So we're celebrating Pride Month this month, and you and I were having a conversation about just what sorts of new issues have arisen clinically in the last couple of years. And I'm just seeing a very big influx of patients who are struggling with a variety of mental health and cognitive concerns, who also happen to be part of the LGBTQ+ community. And the intersection between some of the identity concerns and some of the socio-cultural and political concerns, and how those issues interplay and enhance underlying cognitive and emotional problems. And it has become quite complex. And the degree and severity and intensity of pathology that I am seeing in that patient population has increased, and the patient population age is decreasing. So I am seeing younger and younger and younger patients struggling with a variety of these concerns within this population. And I think as a community professionally, like many other professional communities, we are struggling to learn and to research and to better understand how these complex dynamic issues interplay with one another and the role they play in cognitive and emotional functioning.
You raised so many great and important points there, one of which has to do with this idea of prevalence. So I recently learned that in 1940, we saw a huge surge of left-handed people, not because there were suddenly a bunch of left-handed people being born, but because we were no longer forcing individuals who were left-hand dominant to write with their right hands.
Right, the stigma is decreasing, right?
Yes, absolutely. So I'm interested in how we are seeing the shifts in prevalence for gender identity, sexual identity, and how that's shifting because we are creating more space for people to explore these aspects of their identity, which of course aren't static, but fluid.
Right.
How they're able to now explore these factors in themselves and how that intersects with the medical care that they receive.
You know that, oh,
Yeah,
sorry.
let's hear it.
I know, I think that's so interesting because in this time, and of course, we weren't around when left-handed people were more accepted in terms of society. And I don't know, there are many populations, minority populations that I'm sure have struggled with adaptation and acceptance in various communities. My dissertation is kind of similar to this topic. But in this political and sociocultural climate, it's interesting because on the one hand, there seems to be an openness and an acceptance that's more prevalent now than was before. And concurrently, there seems to be the opposite force also at play, where there is a resistance to the notion of non-binary individuals or trans individuals and such. And so on the one hand, professionally, I hope that clinicians like me, like us, provide that open, safe environment. But I think in this sociopolitical climate, it feels almost as though they are under attack. And so on the one hand, we are seeing an emergence, I guess, so to speak, because in part of that openness to discuss these issues clinically, and but in the community, it seems in certain communities, it's less inclined to do so. And that, I think, creates some of the anxiety and contributes to some of the anxiety that some folks within this community are struggling with.
Yeah, it's so complicated. And on the macro level, which you've already touched on, we have to acknowledge that transgender people in particular are underrepresented
Very
in
much.
creating their own standards of care. So that, of course, trickles down. But I wonder on the micro level or in your day-to-day practice, are there ways that you have found opportunity to adapt your intake, your assessment, your feedback for members of this community?
Yeah, and I'll talk a little bit about Epic. Our computer system now finally has gender identity as one of its elements as part of a checklist that we go through as part of an intake. And just asking about pronouns, what can I call you, instead of assuming that the listed name on a chart is the actual preferred name for a person. Just asking questions like, what can I call you and what pronouns may I use in engaging in that initial first few minutes of a conversation, a lot of times has really opened the door to facilitate communication about issues that patients have told me they otherwise would not necessarily have brought up, for all of the different institutional reasons why many patients don't feel safe talking to their doctors about certain topic or subject areas. So just at the very beginning of the intake, what can I call you? What name would you like to be called? And what pronouns may I use are just two avenues early on that I have found to be remarkably helpful in terms of just opening the door to that conversation or helping a person feel like they are accepted for who they are in this office.
I agree with you. It not only builds rapport and not only creates an invitation for that patient to show us who they are and to feel safe in doing so and to feel welcomed into the evaluation process.
Right.
But I had an experience recently. I heard the term gender euphoria. I don't know if you've heard that term before, but it was a new term for me. And it was explained to me that sometimes individuals of the trans community may feel a sense of euphoria when someone first uses their preferred pronoun, or when they're able to wear makeup for the first time, or able to wear clothes that fit comfortably for the first time.
Yeah.
And I had a patient recently, and I simply inquired, how would you like me to refer to you in this report?
Mm-hmm.
And it was like she had a held breath that she let go of in that moment and said, wow, no one's ever asked me that before. And her affect completely changed. So
Yeah.
it's incredibly meaningful. I agree with you, to simply allow them to take ownership of certain aspects of the clinical process.
That experience brings up a case I recently had where I see a lot of children in my practice and teenagers in my practice. And I recently saw an individual who identified as non-binary, whose preferred pronouns were they, them. and I had the biological parents in the room and the step parents in the room, and two of the parents in the room referred to that individual using their identified pronouns, and two of the parents in the room refused to do so, and instead used the pronouns for the gender assigned at birth. And I could tell just the difference in how that patient was relating to those parents who are identifying them as they are versus the parents who are identifying them as the person they wanted them to be. And I brought that up in that conversation, just saying something like, I've noticed, it can't help but noticed or be noticed that you're not using the preferred pronouns or the preferred name of my patient. Can we talk about that in here? Why is that? And that has facilitated conversations that the patient has told me afterwards they never felt like they could have had with that particular parent or that person. And that has happened so many times in here in the last few years. It's remarkable to me.
It's the opening of a door.
Right.
And the interpersonal ramifications are tremendous. I think that's a fantastic reminder to us as clinicians, and especially as neuropsychologists, that we are also clinical psychologists, and the opportunities to offer interventions and family level interventions. It's not an opportunity to be missed.
Right.
I wonder too about, obviously in neuropsychology, we have the belief that there are some brain differences between males and females just based on biologic mechanisms. And so I'm wondering how you approach normative data.
That's a great question. And sex and gender and identity are such social and religious and scientific and biological schemas, right? They're all so different and so varied. And when it comes to objective testing, what do we do in these scenarios, especially with, someone who identifies as non-binary and they're not sure, or they might be leaning in one direction versus the other? How do we then find a normative sample or normative group that best reflects that particular patient, so that we can gather and generate the most accurate data that we can? And I find this, you and I have talked about this before, this is one of my biggest frustrations within neuropsychology and board certification in neuropsychology, and such is whether or not the normative data that we have accurately reflects the patient that is sitting before us. So in these particular populations, what I do is we score both gender norms and look at and review those data as two separate data sets, and then combine and integrate those two. And a fascinating thing is, perhaps this won't come as a surprise to your viewers, hopefully not, there aren't really that many gender differences in neurocognitive test data scores. I don't know if anyone has ever just run data accidentally or on purpose with both gender norms, but there really isn't a difference, which might come to a shock to a certain small set of our population, but there really isn't. But I would typically run both data set norms.
Here's a question for you. So obviously with neuropsychology, a lot of times the question that we're being asked relates specifically to brain function. But it's so important when there are questions related to hormone replacement therapy or affirming surgeries, and our ability to evaluate risk for things like cerebrovascular disease.
Right.
There may be topics related to that individual stage of life that become pertinent, although not necessarily relevant to the referral question. And do you ever find that, obviously we want to stay vigilant that we're remaining and showing great reverence for the referral question without becoming voyeuristic. But sometimes it's, I find that, at least in my practice, the more information I have, the better able I am to conceptualize a case. Where do you fall on that?
So this is one of my many soapbox issues, actually. I often find that the referral question itself is too limiting. And I my message in my supervision to my peers and my colleagues and trainees has always been never be afraid to ask a question and never be afraid to broaden your horizons, because oftentimes when we are limited to a specific referral question, so I do evals for people who are looking at top and bottom surgery, for example, and it may be specific to capacity or competency or the presence or absence of psychopathology or a cognitive disorder. You know, a lot of my complex patients are on the autism spectrum. They may have had a traumatic brain injury at some point in time. They have a schizoaffective or a psychotic disorder of some sort. And to piece apart these differences in terms of capacity and rationale and decision-making, et cetera, and I'm asked to limit my question to, or limit my answer to one specific question, my response to that is I hardly ever do that. If another avenue opens or another channel of investigation opens during either the consult or during the test data themselves, then I address that issue in the report, honestly, whether I'm asked to or not, and make an opinion about it if I believe that it's relevant tangentially or directly to that referral question. I don't think that we should be limited and limit our questions to just that. And the rationale behind that is because let's look at ADD or ADHD exams, for example. If we're limited to looking at whether or not someone has an attention deficit disorder, and we base our testing only on a specific test that we gave regarding attention and the history taking and the record review, and we don't consider could there be alternative explanations as to why someone's attention might be compromised, we may then support a diagnosis for an attention deficit disorder, even though that's not what it is. It could be something else or being caused by something else. And so I try to bring that approach to all of my cases, but especially cases such as these.
I agree, because the referring provider doesn't know what they don't know.
Right.
And many times the referring provider is not a mental health, qualified mental health provider. So they may not even recognize some of the behavioral indicators of psychopathology or developmental disorder. And you're right, part of our job is to not only be assessing for things relevant to the referral question, but also looking for things that we know could potentially influence that patient's functioning day to day, their overall quality of life, and therefore treatment planning that needs to be considered.
Agreed. I think we have an opportunity to look through a window into the mind and into the soul. And I think we could use that to benefit our patients by looking through both of those avenues and to exploring what it is that we see when we're there. It's a humbling opportunity that I think we should take advantage of, the opportunity that we have to look and gain as much insight as we can. I think holistic medicine, or looking at comprehensive care, multidisciplinary care, is becoming more important. And I think we ought to apply those techniques to our own practice.
Absolutely. And for me, one of the areas that I think is often overlooked, and I tend to be rather vigilant about, is the assessment of trauma. And not just the traditional acute traumas, but also more complex forms of trauma that may have occurred during the developmental years, or chronic traumas, prolonged exposure to stressful events. And within the LGBTQ community, I think it's so important that we not be remiss about the possibility of these individuals having experienced verbal harassment, acts of violence, or things that may have had catastrophic outcomes that have led to them losing their jobs or their homes or their families. So, and I don't think, like, we talked earlier about normative data. I don't think that we necessarily have measures that are as of yet sensitive to some of these kinds of trauma. And I think there's also probably some publication bias, because publications tend to, be more relevant to the dominant group. So I wonder what approach or what nuanced approach you have to assessing for trauma in this population.
And that's almost, oh, this is such a great content area. That's always such a part of a good history taking, especially if I'm seeing a child or adolescent, one-on-one time with them, asking these types of questions, versus using standardized assessment questionnaires that don't look at or don't even ask the question. So many of our objective measures give you a checklist of what traumas you have to have experienced. And if you don't check off one of those boxes because your experience doesn't fit into one of these neatly defined categories, now all of a sudden you're ending up with a PTSD negative, or you don't even have the opportunity objectively to look at symptoms because the test is discontinued at that point. So a good history taking and asking those types of questions as you navigate through not only the intake, but also the testing process, and reviewing those questionnaires before, the patient leaves the office, and taking a look at what you have, and then using that as an opportunity to then take that questionnaire and pursue it. If that person has disclosed, my parents never identified with who I am, right? I was never acknowledged for the person that I am, which is incredibly traumatic over quite a sustained period of time. And then using that as your index trauma to then ask other questions about whether or not these other diagnostic criteria are present or are not present. And then using that information to more accurately or definitively look at, is that where their anxiety or depression or cognitive issue comes from, is remarkably helpful.
And I would take it even a step further and say it informs treatment planning, because then we can really start to look at what are the primary clinical targets, what are the secondary clinical targets. If we need to take a stepwise approach to treatment, where do we need to start?
Right.
What do we look as maybe more long-term? And we know, of course, with complex forms of trauma, you're at higher risk for all kinds of things, whether it be somatic symptoms, generalized anxiety disorder, even characterological traits. So we need to be able to be thorough and comprehensive, but also have an idea to the degree that we can about what is causing what.
Right.
And where do we need to start? Language is obviously so very important in our profession and in healthcare in general. I have found personally that the language used by this community is evolving very, very quickly. Is there a way you've found to stay current in that respect?
The internet is such a great resource. There are a number of really good websites out there that provide a glossary of terminology that is being used. And I just find that as an aging neuropsychologist, that in any population, especially with younger generations, terms that are being used are just things I've never heard of before. So in clinic, I'll just ask the question, what does that word mean? The other day, the word was situationship. I said, what's a situationship? Oh, and then they said, well, it's, you're in a relationship, but it's not serious. It's just your situation. It's a situationship. And I wrote it down on a Post-it note. Yes, I have to now integrate this new term into my lexicon. And I maybe once a month go on and review and just read articles and discussion groups on Reddit, on the general internet, to just look at glossary of terms and try to keep myself appraised and up to date as to what sorts of language and terms are being used, because that's evolving as well, just as the English language in general is evolving. And so I think keeping up to date on that and asking the question, it is okay to ask your patient questions about themselves, and it is okay to clarify when they're using terms or terminology that we don't quite understand or we're not sure of. For me, it's a great way of just reestablishing or maintaining rapport. I don't know what that means. Can you tell me what that means? I'd like to be educated on this. Can you teach me something about what does that term or phrase mean? I'm happy to ask that question. I think it's important to just keep looking into it.
And another mechanism that I think that serves is it helps distribute the power or redistribute the power, because right off the bat, it's doctor patient,
Right.
And there's that inherent power differential. But when you say, hey, teach me what this language means, teach me how you see yourself, teach me how this plays out in your family, teach me how you've experienced the world because of how you see yourself and how others see you. Right. Automatically, we redistribute that power, which I think is a corrective experience, or certainly has the potential to be. It also allows us to continue learning and being other oriented and being affirming in our approach. But it also, I think, allows us to be tailored in our assessment of that individual and in the diagnostic conclusions that we draw, which are obviously so essential.
It's just a way of asking that question, help me see you. I'm trying to see you and I need your help. And I don't think that there's anything negative about that, even if the outcome is, I don't want to talk about that. This is a boundary that my patient is setting or they don't feel comfortable. That's another avenue or channel to explore. Right. And it's just another method of kind of getting in there and figuring out, what's happening up here.
Where do you think, this is perhaps just such a broad question to consider, but where do you think some of the biggest health disparities are for members of this community?
Oh, there are many health disparities, many. I think we could start with access to care. Right. So we are used to treating a patient that has a diagnosis or a set of diagnoses, and we have a set treatment plan for this is what we do in this scenario. ADHD, dementia, traumatic brain injury, what have you. Is a set of protocol. Here's a set of things that we need to do or establish or maintain in terms of treatment plan and academic accommodations or vocational accommodations and medication management and behavioral interventions and therapy options, et cetera. But in this specific patient population, the access to care is fundamentally limited. And in certain states now, we will be punished for providing that level of care or that access to care. And I think that inhibits a patient from seeking help to begin with. And that inhibits the amount of help or the ability or opportunity that we have to help a particular patient. And I think access to care is probably the biggest limit that I see. And then the lack of education on our side clinically about the patient population in general, the normative data and the statistical methodology and the statistical power that we have, or I guess we lack, in terms of identifying and assessing for early onset dementias or other conditions where having those norms are really critical in delineating between what is quote unquote normal and what is quote unquote abnormal. And it's frustrating.
And normative data, not only related to our specialty, I think with respect to neurocognitive tests and the measures that we give, but also beginning to understand how the members of this community need to be screened for risk,
Right.
Related to maybe hormone replacement and how that interacts with risk for cancer versus what we know about screening for cisgender individuals. I mean, there is just a long way to go. And in the meantime, bridging that gap or bridging those gaps where we can, I think it is meaningful. Are there things that you think you and I can be doing to move the momentum of that forward, in addition to what we've already discussed today?
I think in conversation with our medical colleagues and our psychological colleagues and psychiatric colleagues, I think an example comes to mind where I had an endocrinologist send me a patient because the labs were just all over the place, couldn't get thyroid levels under control. They were considering testosterone versus estrogen, and this person was experiencing significant cognitive changes and emotional ability. And we examined the patient with neuropsych testing. And as part of that, we sent for genetic testing. It turns out the patient had a mild form of Turner's. And without having that knowledge and awareness, and this was a transgender individual, without having those conversations just across the lunch table with our medical colleagues, none of this would have come to light. And instead, this patient would have probably been put on hormone replacement therapy that they didn't need, or the opposite of what they had in fact needed. So I think some of this really comes down to just communication and conversation. We have to acknowledge our limitations, and if we have clinical questions, we ought to ask them, and also to recognize that we have a limited scope through which we're looking at information as well, and that we can rely on other professionals in other specialties to help provide that degree of insight so we can get a better sense as to the whole circle that is that person. So I think things that you and I can do, and what we should be doing, is engaging with the medical and professional community within which we work, to make sure we are truly understanding that person medically and biologically and psychosocially and physically, as well as through the specific domains through which we're looking at. And we educate them as much as they educate us.
Agreed. And you highlighted the idea of communication. Having the dialogue, making sure that our reports communicate clearly and succinctly. I think also staying involved in legislation to whatever degree our profession allows, and ensuring where possible that the right hand is talking to the left. Because in a case where there are all these medical comorbidities and psychiatric comorbidities, you've got a number of providers, a number of specialists. They may not be sharing the same medical record. And, picking up the phone and calling and saying, are you aware that, for example, the medications that this patient is being prescribed may actually be interfering with their cognitive functioning, for example. So yeah, again, ensuring that the left hand is talking to the right, even if that means becoming an advocate beyond what we would traditionally think our responsibility to do would be.
It always fascinates me how much we assume that we know about a person, and how much we rely on the assumptions that we have made about a person without ever having factually or objectively verified whether or not those assumptions are true. And I find that to be true across medical subspecialties as well. And the more open the communication and the more we make ourselves available to new information, to communication, to admitting and acknowledging those areas of our knowledge that we lack, the gaps in our own knowledge and awareness. And then the more we advocate for our patients and be the voice for them when they can't have a voice as strong as perhaps ours are, all of those, I think, are really critical things that we as a profession should be doing.
You're exactly right. And part of it is beginning to, or continuing to, recognize our own implicit and explicit biases.
Yeah.
Because we do have certain unconscious prejudices and biases. And the more insight we can bring to that as providers, I think the more we can minimize those biases and certainly begin to mitigate the impact that they have on our patient care. I love that Harvard tool where you can, I don't know if you've ever done it, the Stroop test, where you can look at some of your unconscious biases.
And it's, it swings both ways. A lot of times the pendulum, we always view ourselves as less biased and view the other person perhaps as more subjective or more vulnerable or susceptible to bias. But it moves both ways. And in this particular community, I have younger folks or teenagers who might think that they are trans and identify in that particular way as having a trans related identity. And my presumption or my bias might be to accept that is the true nature of who that person is, because I'm so wanting, or I'm desiring so much to be accepting, that I'm accepting a situation for what it is and not considering that maybe there's a depression or anxiety issue or some other component or element or social or peer pressure issue that's going on that's causing a person to believe that particular issue. And if I don't allow that opportunity to explore where is this coming from within myself, I might swing on the bias side to that side of I'm just accepting everything. And on the flip side of that, it's I'm not accepting this at all because I don't believe in it. So I think just having that constant awareness and that self-feedback, I call it, the meta-analysis of yourself, and where do I sit in the room with these situations, I hope helps reduce the effect that my biases can have on any particular clinical case.
Right. You raise a good point that we want to meet the patient where they are. We want to embrace how they see themselves, but I don't think we want to lose sight of the objectivity and the clinical know-how that we bring to the table.
Right.
An example for me, I met an individual several years ago who was having some pretty significant identity related distress. But when we did the evaluation, we were able to see a borderline personality disorder that had a lot to do with that unstable sense of self and the instability with identity. And so recognizing that is the primary clinical target and hitting the pause button on some of the other diagnostic pieces until we could adequately address that and clear up the mood lability and the self-identity dysregulation, and then circle back and see where we were. So I agree, we don't want to lose the objectivity, and I think we owe it to our patients to bring that to the table and have that be part of the collaborative process.
Definitely. I have a feeling we'll be seeing more of this, and perhaps eventually one day literature about this in the population of patients who have mild or high functioning autism spectrum issues, because I have been seeing quite a bit of that lately in terms of the influence, societal influence, fitting in, feeling different, and looking at comorbidity and any other issues that might be contributing, causing, or it may be not related at all to these issues.
It's the future is, I think, exciting, not only with respect to research and the questions that we're asking, but there's the layer of the pandemic and the ways in which that has sort of wiped the slate clean and is allowing us to explore things in a new way and address things in a new way. So much discussion to be had, and I'm so grateful to be able to have discussed it with you today. As we sign off, I would like to ask, what would you say is the most valuable lesson that members of this community have taught to you?
Be open to asking questions.
Excellent. Thank you so very much for your time today, Dr. Khawaja.
Well, thanks for having me. It was a pleasure. Thank you so much.